Hello. Today we should talk about vasculitis. So what does it mean? Vasculitis generally means inflammation of the vessel wall, but in practice we tend to reserve the term vasculitis usually for non-infective immune-mediated inflammation. So the direct translation of the term vasculitis is very general. It means just the inflammation of the vessel wall. But in practice, we use the term usually for immune-mediated diseases. But the overall etiology is quite broad. It can be immune-mediated process, as I mentioned, which is the vasculitis sensu stricto. But a lot of infections can cause inflammation of the vessel wall as well. You know, or maybe you know, syphilitic aortitis, which is one of the manifestations of the third stage of syphilis. Mycosis can cause vasculitis as well, because a lot of mycotic infections are angioinvasive. They like to invade into the lumen of the vessels. So the mycotic vasculitis is not exactly rare. Or it can be bacterial infection. It's usually the spread from adjacent focus of the inflammation, and bacterial inflammation can affect the adjacent vessel as well. Radiation can induce the inflammatory injury of the vessel wall, and the same goes for several toxins. And also we should include non-inflammatory vasculopathies. Why should we talk about them? Non-inflammatory vasculopathies is a group of diseases, of the vessels, which are primarily non-inflammatory, but they can be quite similar to vasculitis from the morphological point of the view. There can be the thrombotic microangiopathy, which is not one disease; it's a group of the diseases, and generally they are manifest as multiple microscopic thrombi in small vessels and capillaries. Some of the diseases can be systemic, some of the diseases can be more organ-specific. Trauma of the vessel wall could be included as well. And hypertensive and diabetic angiopathy. It's quite important because hypertensive and diabetic vascular injury is quite common, especially in older patients. And in some instances, they can mimic vasculitis on the morphological level, because if the hypertension is severe enough, if the patient develops so-called malignant hypertension, it can induce fibrinode necrosis of the vessel wall. And fibrinode necrosis, we will talk about it later in the next minutes. We will discuss that the fibrinode necrosis is one of the typical manifestations of vasculitis. It's a special type of necrosis of the vessel wall. But the hypertension, the severe hypertension, can cause fibrinode necrosis of the vessel wall as well. So it can mimic vasculitis, and we should keep this in mind. So if you see a vessel with a fibrinode necrosis, it may be vasculitis, but it can be also a hypertensive angiopathy, and we should keep it in mind. What about the clinical symptoms? Before we start, I should mention one thing. Vasculitis, the topic of vasculitis, let's say it is not exactly the most favored topic for the both undergraduate and postgraduate students, or pathologists. And I think the good way how to study and how to remember vasculitis, how to learn this topic, is to realize what is general and what is specific for the given diseases. Because a lot of clinical symptoms are quite common, and they are quite general, and they are general for all or almost all vasculitis. And there's no need to memorize the same symptoms for each specific disease. The same goes for morphology. The majority of the morphological signs or morphological features are general, and they are same for all or almost all diseases. So again, there's no need to learn 20 times that the vasculitis can present with the inflammation of the vessel wall, because it's general. So I think the good way how to learn this topic is to realize what is general and what is specific for the given diseases. And if you do it this way, and we will do this lecture this way, you will realize that the specific informations that are required for the given diseases, it's just 2 or 3 sentences, nothing else. So let's say 80% of the information regarding this topic will be general, and it will be the same for the majority of the diseases. So back to the clinical symptoms. They can be classified as local and systemic. The local symptoms, I think you could think about all of them, because the symptoms usually develop as a consequence of the damaged vessel. So if you have inflammation of the vessel wall, and if you damage the vessel wall, you also damage endothelium. And if you damage endothelium, there is a huge risk of thrombosis. And the thrombosis can lead to acute ischemia. So the patients with vasculitis can manifest signs of acute ischemia, necrosis, myocardial necrosis, for example, kidney necrosis, kidney infarction, or ulcers if the vasculitis affects the mucosa or the skin subsurface. If the ischemia is milder, or the affected vessel has a bigger diameter, aorta for example, it leads to the narrowing of the vessel, and the consequence doesn't need to be a necrosis, but it can lead to vascular atrophy of the organ or of the tissue. Or the problem or the symptom can be functional only, without any morphological correlate. Patients can manifest claudications, syncopes, and many other symptoms. So that was ischemia. But the vessel is affected by inflammation. So the wall of the vessel is infiltrated by inflammatory cells, and the vessel and the wall of the vessel is thin. It's thinner, and such vessel can bleed. It can burst and bleed. So the hemorrhagic complications are quite common as well. So as you see, those patients with vasculitis typically manifest the symptoms from the both ends of the spectrum. They can manifest signs of ischemia, acute or chronic, and they can manifest signs of hemorrhages at the same time. Some vasculitis are accompanied by granulomas. Not all of them, but in some diseases you can manifest or you can see also granulomas. And we should mention, or we should stress, that the symptoms largely depend on the locality and diameter of the vessel. Some vasculitis, some diseases can affect lungs, some diseases can affect GI tract, some diseases can affect kidneys. So the symptoms will vary according to the locality. The patients can also have a lot of systemic symptoms. Usually the vasculitis is a systemic disease, and in this lecture we will talk mainly about the systemic diseases. And so the vasculitis is an inflammatory process and it's systemic disease. So the patients can often manifest systemic signs of inflammation. So they can have a fever, they can be fatigue, or they can experience joints and muscle pain. Some diseases can be accompanied by allergic reactions, and we will talk about it later. How do we classify them? How do we classify vasculitis? We can classify those diseases according to caliber of the affected vessel and presence of ANCA antibodies. With regards to the caliber, we can subclassify those diseases as large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Large vessel vasculitis affects aorta and the biggest branches. The medium vessel vasculitis affects medium-sized muscular arteries, and the small vessel vasculitis affects small arteries, arterioles, especially arterioles, capillaries, and venules. But please keep in mind that the size or the caliber of the affected vessel means the smallest caliber possible. In other words, large vessel vasculitis affects large vessels. Medium vessel vasculitis affects medium-sized vessels, but less commonly it can affect also large vessels, but it shouldn't affect small vessels. And again, the small vessel vasculitis usually affects small vessels, arterioles, venules, capillaries, but less commonly they can affect medium-sized or even large arteries. So again, we are talking about the smallest diameter possible. So some typically small vessel vasculitis, like ANCA-positive vasculitis, can affect aorta. It's quite rare, but it can happen. But some typical aortic disease, such as Takayashu arteritis, for example, or temporal arteritis, shouldn't affect capillaries, for example. So we are talking about the smallest caliber possible. And we will talk about those diseases. Large vessel vasculitis includes two of them, giant cell or temporal arteritis, or the synonym is Horton's disease, and Takayashu arteritis. Medium-sized vessels include polyarteritis nodosa, Kawasaki disease. And small vessel vasculitis are subclassified according to presence or absence of ANCA antibodies. ANCA-positive small vessel vasculitis includes granulomatosis with polyangiitis. The older and more known term is beginner's granulomatosis. Then there is a microscopic polyangiitis and so-called eosinophilic granulomatosis with polyangiitis. Older term is Church-Strauss syndrome. And ANCA-negative small vessel vasculitis includes anti-GMB vasculitis, which means vasculitis with antibodies against glomerular basement membrane, and IgA vasculitis. Again, older term, which maybe you will know better, is Henoch-Schönlein purpura. This is quite important. Please keep in mind, final diagnosis of the specific vasculitis, of the specific disease, is clinical. Pathologist cannot make a diagnosis of the specific vasculitis. A lot of vasculitis share the same morphological appearance, and the final diagnosis is clinical. Each vasculitis has quite complicated diagnostic criteria, and they include clinical signs, some laboratory findings, histological findings, and many others. So the final diagnosis, the definitive diagnosis of the specific vasculitis is a clinical, not a pathological. Pathologist is just one piece of the puzzle. Usually, the microscopy, the pathologist recognizes caliber of the affected vessel and presence of fibrinoid necrosis. So we can say this is the small vessel vasculitis, for example, with or without fibrinoid necrosis. But the specific disease, the diagnosis of the specific disease, is a clinical job. Generally speaking, the main task for pathologist is to recognize the vasculitis. So our main goal, our main job is to recognize that the disease is vasculitis. What about the morphology? How the vasculitis looks like? The majority of the morphological changes we can appreciate is the same for all vasculitis, but there are slight differences that can lead us, or that can point us to the specific diagnosis. Vasculitis is an inflammatory process, so there will be inflammation of the vessel wall. It will usually consist of lymphocytes and neutrophils. Sometimes there can be quite a lot of eosinophils in some diseases. And the inflammation disrupts the structure of the vessel wall. So we will see fragmentation of the elastic membranes, activation of the endothelium. And sometimes there can be fibrinoid necrosis. The presence or absence of the fibrinoid necrosis is very important for the diagnosis. Some vasculitis, some diseases can be accompanied by granulomas as well. We can see granulomas, like a fully developed granulomas, or just the giant cells without granulomas. So in some diseases there can be just scattered giant cells, giant macrophages, and in some diseases there can be fully developed granulomas. And later on, because the vasculitis is usually chronic disease, so later on there will be scarring, so there will be fibrosis of the vessel wall, narrowing of the lumen, and reduced elastic membranes because they will be damaged by the inflammation. You can see it here. This is the picture of the vasculitis. This is the artery, and you see there's a huge amount of inflammatory cells. There's a huge number of cells such as lymphocytes, plasmacytes, and neutrophils. The lumen of the vessel wall is obliterated, and this ribbon, this bright pink ribbon, this is fibrinoid necrosis. Fibrinoid necrosis is called fibrinoid because it looks like fibrin. It has the same appearance, it stains the same. So fibrinoid means fibrin-like. And this is fibrinoid necrosis. So this bright red band, this is fibrinoid necrosis. That's how it looks like. And as I said, the presence or the absence of fibrinoid necrosis can lead us to the specific diagnosis. Later on, in the chronic phase, there will be scarring. You can see it here. This is the vessel wall, or this is the vessel in total. This is the tunica media, and this is the intima. And you can see the tunica intima is hugely expanded by fibrosis, and the lumen of the vessel is very small, it's very thin and narrow. So this is the huge fibrosis of the tunica intima caused by chronic inflammation. You can appreciate also quite a lot of inflammatory cells, and this is tunica media. And you see the inflammation is also in adventitia. This is the special staining called Weigert van Gießen with elastic staining. Weigert van Gießen stains muscle, which is red. It stains muscle, which is yellow. This is tunica media, and fibrous tissue, which is red. This is adventitia. And you see there's a lot of fibrosis in the vessel wall, and those black bands, these are elastic membranes, and you see they are disrupted, they are reduced, and there are some regions in which the elastic membranes are completely absent. So this is the chronic phase of vasculitis. And as you can see here, the lumen is occluded by thrombus. As I mentioned earlier, some diseases can be accompanied by more specific changes. And some vasculitis, in some instances, you can see giant cells. You can see it here. This is the vessel wall, which is fibrotic. There is some inflammation, and you can appreciate a lot of giant cells. Those cells, they are giant macrophages, multinucleated macrophages. Okay, so this was the general part of the lecture, and now we will discuss the specific diseases, and we will start with the large vessel vasculitis, and then we will continue to middle-sized and small vessel vasculitis. As I mentioned earlier, large vessel vasculitis includes two diseases, giant cell and Takayasu arteritis. Microscopically, they are the same. So the giant cell vasculitis and or arteritis and Takayasu arteritis, microscopically they look the same. So the clinical context is necessary for the proper diagnosis. Giant cell or temporal arteritis is a disease that affects typically older patients, usually above 50 years. And the typical localization is a muscular artery of the head, typically temporal artery. That's why we call it temporal arteritis, because it usually affects temporal artery, but not in all cases. And the clinical symptoms are typical because those patients usually manifest headaches. They can have impaired vision because the disease can sometimes affect the ophthalmic artery, and they can have jaw claudications. They can have ischemic pain in chewing muscles because of the ischemia. Microscopically, there is a typical inflammation of the vessel wall with giant cells, because it's called giant cell arteritis, without fibrinonecrosis, which is quite typical. If you see fibrinonecrosis in the large vessel, you should always consider atypical presentation of ANCA-positive vasculitis, which is usually a small vessel vasculitis. So the microscopically there is a inflammation of the vessel wall with the giant cells and no fibrinoid necrosis. And later on there will be disruption of the elastic membranes and scarring. In this region the elastic membranes are quite okay, but in this region the elastic membranes are disrupted, they are twisted, they are fragmented and reduced, and there is a scarring in the middle. Takayasu arteritis is the second disease from the large vessel vasculitis group, and as I said, microscopically it looks the same, and we need the clinical context. Takayasu arteritis typically affects young adults, especially females, and usually it affects the people in Asia, in Asian countries. The localization is different as well, because Takayasu arteritis usually affects aorta and large branches. You can see it here on the angiogram with multiple narrowings on the main branches of the aortic arch. Therefore, the clinical presentation will be different as well, because those patients will usually experience muscle pain, claudications, and soft pulse in upper extremities. They can have headaches, impaired vision, syncopes, or various neurological symptoms. And as I mentioned, the histology is the same. Okay, so that was large vessel vasculitis group, and then we will move towards the medium-sized vessel vasculitis. You should definitely remember polyarteritis nodosa. Polyarteritis nodosa, it used to be a common disease, but later on the diagnostic criteria changed and they are quite strict, and that's why the polyarteritis nodosa is quite a rare disease nowadays, but it's severe disease if not treated. Histologically, it's a necrotizing vasculitis, so there is a fibrinoid necrosis, so the presence of the fibrinoid necrosis is typical for polyarteritis nodosa. And because it's medium-sized vessel vasculitis, the small vessels shouldn't be affected. So if you see a vasculitis that affects the medium-sized vessels, doesn't affect small vessels, and there is a fibrinoid necrosis, you can be pretty sure it will be polyarteritis nodosa. Because the small vessels are not affected, there is no glomerulonephritis, for example. Because you should know that the glomerulonephritis, the inflammation of the glomeruli, is quite typical manifestation of vasculitis generally. But glomerulus it's a capillary. It's a mesh of capillaries. And so the only small vessel vasculitis should affect glomeruli. And polyarteritis nodosa shouldn't affect glomeruli from the definition. It affects kidneys quite often, but just the larger vessels, larger arteries, not glomeruli. And ANCA antibodies are usually not present. So again, it's the vasculitis of the medium-sized vessels without fibrinoid necrosis and without ANCA antibodies. This is polyarteritis nodosa. Microscopically, the injury is segmental. Typically, you can see segments of the fresh injury, of the active inflammation, and segments of older injuries with fibrosis, with scarring. So there are alternating segments of scarring and inflammation. And the segments that are scarred are narrowed, and the segments that are affected by active inflammation, they are often dilated because the vessel wall is soft and the segment is prone to aneurysm. So if you do, for example, an angiography, you will see that the affected vessel looks like bats on the string. It looks like a pearl necklace because there are narrow segments of the fibrosis and dilated segments, the small aneurysms that are affected by active inflammation. That's why we call the disease polyarteritis nodosa, because you see multiple nodules on the vessel. So this segmental injury with alterating of the fresh and older injuries, it's also a typical feature of polyarteritis nodosa. And as I said, the disease quite often it affects kidneys, but no glomeruli, because it shouldn't be a small vessel vasculitis. But it can affect other organs as well, such as heart, liver, GI tract. And you saw this picture before. This is the middle-sized artery, medium-sized artery, affected by inflammation, and there is a fibrinoid necrosis. So that's how polyarteritis nodosa looks like. Second disease from this group is Kawasaki's disease. Kawasaki disease, again, the histology is the same, the microscopy is the same as polyarteritis nodosa, but this disease usually it is not biopsied. So the pathologist usually don't see this disease because this disease have a typical clinical presentation and the diagnosis is usually made on the clinical grounds. Kawasaki disease usually affects small children, usually up to 5 years, and the typical locality is coronary arteries. That's why those children often develop ischemic complications of the heart. They can develop even myocardial infarction in a very young age. And also, the Kawasaki disease is typically accompanied by so-called mucocutaneous syndrome, which is a triad of following diseases or following symptoms. Those children usually manifest erythema, blisters, and various defects on conjunctiva and oral cavity mucosa. That's the first thing. Second thing is erythema and rash on the skin, typically palms and soles. And third is a cervical lymphadenopathy. So this triad with the oral cavity defects on the conjunctiva, erythema and rash on the palms and soles, and cervical lymphadenopathy, with combination with the vasculitis that usually affects coronary arteries, that is Kawasaki's disease. So as you can see, the clinical presentation is quite typical, and usually no biopsy is done in this patient. But histology is the same as polyarteritis nodosa. And last but not least, small vessel vasculitis. As I mentioned before, small vessel vasculitis affects arterioles, capillaries, and venules. Quite often, it affects mainly venules, especially in skin localization. And we subclassify this group of diseases according to presence or absence of ANCA antibodies. ANCA-positive vasculitis or ANCA-positive small vessel vasculitis usually develop fibrinoid necrosis. So if you see small vessel vasculitis with fibrinoid necrosis, it's usually ANCA-positive vasculitis. ANCA-positive vasculitis is usually it's a group of diseases, and this group usually affects the adult patients, and the disease is quite severe if not treated. But those diseases in this group share very similar histology and clinical presentation. But there can be some slight differences that can point us towards the specific diagnosis. We should mention 3 of them, and it is granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis, microscopic polyangiitis, synonym is microscopic polyarteritis nodosa, and eosinophilic granulomatosis with polyangiitis. Again, all the term is Church-Strauss syndrome. Basically, any organ can be affected in those patients, but usually the lungs and kidneys are affected in most of the cases. Those patients usually develop systemic symptoms, so fever, fatigue, muscle and joint pain, it's quite typical for them. And the disease has usually undulant clinical course. So there is alteration of active disease and spontaneous regression. So the patients experience episodes of active disease and episodes of spontaneous regression in which the clinical symptoms will fade away. And as I said, microscopically, there is a vasculitis or small vessels with fibrinoid necrosis. Now let's talk about the ANCA antibodies. How do we detect them? We can detect ANCA antibodies using immunofluorescence or using enzyme-linked immunosorbent assay. Nowadays, we do it usually by ELISA. In immunofluorescence, we can subclassify ANCA antibodies into cytoplasmic and perinuclear, C-ANCA and P-ANCA. C-ANCA are typical for Wegener's granulomatosis, so granulomatosis with polyangiitis. P-ANCA are typical for microscopic polyangiitis. But in these days, we usually classify or subclassify ANCA antibodies by ELISA. And by ELISA, we can subclassify it according to a specific antigen against which they are aimed. So we can subclassify ANCA antibodies against proteinase 3, which is typical for Wegener, and ANCA antibodies against myeloperoxidase, which is typical for the rest, for the microscopic polyangiitis and Church-Strauss syndrome. Wegener's granulomatosis or granulomatosis with polyangiitis. It usually affects respiratory tract, but what is quite typical, it doesn't affect only lungs, but it also affects upper respiratory tract. So the inflammation with a quite destructive process of the upper respiratory tract, such as nasal cavity, paranasal sinuses, or trachea, it's quite typical for this disease, because other vasculitis that affects respiratory tract, they usually affect lungs, but Wegener granulomatosis quite often affects also upper respiratory tract, which is quite typical. And microscopically, the inflammation, the vasculitis, is often accompanied by granulomatous necrotizing inflammation. So granulomas, necrosis, and vasculitis. It is typical for Wegener. So if you see this process in lungs, the main differential diagnosis is tuberculosis, because you will see necrosis and granulomas. So if you see granulomas and necrosis in lungs, you should consider definitely TBC, but you should also carefully search for the presence or absence of vasculitis, because it could be also Wegener. Microscopic polyangiitis has a variable localization. Microscopically, it's quite similar to polyarteritis nodosa. That's why we call it microscopic polyarteritis nodosa as a synonym. But in contrast to true polyarteritis nodosa, microscopic polyangiitis affects small vessels, and the injuries are of the same age, in contrast to polyarteritis nodosa. And the last is eosinophilic granulomatosis with polyangiitis, which is also called, or which used to be called, Church-Strauss syndrome. And this disease is characterized by numerous eosinophils. They are not entirely specific for this disease, but they are quite typical. So if you see vasculitis with numerous eosinophils, there is a quite high chance it will be Church-Strauss syndrome. And those patients typically develop allergic reactions, such as asthma or hay fever. They can have peripheral eosinophilia in peripheral blood, or they can develop the eosinophilic myocarditis, which means inflammation of the heart muscle. So numerous eosinophils and allergic reactions accompanied by vasculitis, it's quite typical for Church-Strauss syndrome. And the last group, ANCA-negative small vessel vasculitis. This group is usually rare. Those diseases are quite rare, and often they affect skin, kidneys, and lungs. But the skin is quite often affected. And you should remember two of them. First is vasculitis with antibodies against the glomerular basement membrane. So, and because it's a small vessel vasculitis, the glomerulonephritis is quite typical for those patients, especially RPGN, which means rapid progressive glomerulonephritis. We will talk about it later in some other lecture. And sometimes this disease is accompanied by lung damage, lung manifestation. And the combination of kidney and lung manifestation is called good posture syndrome. So the good posture syndrome is not exactly the synonym of anti-GMB vasculitis, because you need to have both lung and kidney manifestation. And the second is IgA vasculitis, formerly known as Henoch-Schönlein purpura. This disease is typical for children. Glomerulonephritis is quite typical for those children, and there is a typical clinical sign, and it's purpura on buttocks, on the skin of buttocks. So children with glomerulonephritis and purpura on the buttocks, it's quite typical for Henoch-Schönlein purpura. And then this is basically all. As you can probably guess, there's quite a lot of vasculitis which we won't cover today, but I think this is definitely enough for the undergraduate level. But maybe we should mention few others. You should remember Bacter disease. This is disease that affects the usually small and medium-sized vessels, and the typical manifestation is GI tract. It usually affects GI tract. Sometimes it can affect also lungs, but the GI manifestation is quite typical. And it can mimic Crohn's disease. It can mimic Crohn's disease on the macroscopic level, which means endoscopically, and it can mimic Crohn's disease also microscopically. So if you see something that looks like Crohn's, but you are not sure, or the patient doesn't react well to the treatment, you should consider Bacter disease. And there is a typical triad along with the vasculitis that can help you with the diagnosis. Those patients typically develop F-Tos ulcers in oral cavity, genital lesions, genital ulcers, and uveitis. So the patients with a disease that looks like Crohn, with F-Tos ulcers in oral cavity, genital ulcers, and uveitis, it's quite typical for Bacter disease. And the last disease that you should remember is thromboangiitis obliterans, or Berger's disease. This vasculitis affects usually medium-sized and small vessels of the extremities, especially tibial and radial artery. And this is a typical disease of the smokers, of the heavy smokers. So adult heavy smokers are risk group for Buerger's disease. We don't know exactly what's the pathogenesis. It can be some sort of weird allergy to tobacco. It can be caused by direct toxin effect of the tobacco to the vessels. We are not sure, but the heavy smokers are usually the patients with Buerger's disease. The lesion is typically segmental, and the inflammation typically affects not only the artery but also the adjacent vein and nerve. So the whole bundle of the nerve, artery and vein is affected by the inflammation. And as a result, this patient typically developed claudications. They can have a Raynaud phenomenon on the fingers, and later on they can develop ulcers or even gangrene with amputation of the digits. The claudications are typically localized in soles, which is quite typical, because usually the claudications are consequence of atherosclerosis of the lower extremities. But the atherosclerosis of the lower extremities arteries is usually situated more proximally. So also the claudications are more proximally situated. But the claudication in soles, this is not exactly typical for atherosclerosis. So if you have a patient, when you have a patient with a claudication in soles and the patient is a smoker, you should always consider Buerger's disease. And microscopically, there is a vasculitis, so there's an inflammation of the vessel wall. So this is the vessel, there is the inflammation, and the inflammation typically contains a lot of neutrophils. It looks almost like a phlegmon of the vessel wall, and there is a thrombus in the lumen. The thrombosis of the lumen is very typical for this disease. That's why it got its name angitis, because the thrombus in the vessel wall is very typical. So the inflammation of the vessel wall with numerous neutrophils and thrombus in the lumen, and especially tibial and radial artery, it's quite typical. So that's basically all. If I recapitulate it, again I need to stress that the final diagnosis of vasculitis is clinical, and the pathologist can basically recognize giant cell arteritis of large arteries. So we can see vasculitis of large arteries with the giant cells, which can be Takayashu or temporal arteritis. But to recognize those diseases, it's a job for clinician. So we can tell this is the giant cell vasculitis of large arteries and nothing else. And the clinical context is necessary for the diagnosis. Then we can recognize medium-sized vasculitis with fibrinoid necrosis. If you see vasculitis that affects medium-sized vessels but doesn't affect small-sized vessels, and there is fibrinoid necrosis, it's usually polyarteritis nodosa. It can be Kawasaki, but as I said, it's rarely biopsied. And then we can see small vessel vasculitis with fibrinoid necrosis. It's usually ANCA-positive vasculitis, or without fibrinoid necrosis, which is the rest. And that's basically all. And just a few notes at the end. Sometimes you will hear the term secondary vasculitis. Secondary vasculitis means vasculitis as a part of other usually systemic disease, because vasculitis can accompany various systemic diseases, usually autoimmune or rheumatoid. Lupus, for example, or IBD can be accompanied by vasculitis. Some vasculitis are organ specific, or they can accompany congenital disorders. But this topic goes beyond the undergraduate teaching, because there is a lot of other vasculitis that can be organ specific, and we won't cover them because it would be just too much. And sometimes you can hear the term leukocytoclastic vasculitis, which is not a diagnosis. It's not a specific diagnosis. It's a rather descriptive term that describes small vessel vasculitis without fibrinoid necrosis. So it's just a descriptive morphological term. It's not a specific diagnosis. And this is the last slide for you. I included a few hints for the clinical practice. When should we consider vasculitis? in oral otorhinolaryngologic region, in head and neck region. If you face pediatric disease in adult age, for example, recurrent otitis, which is not typical for adults, you should consider vasculitis. On the skin, when dermatologist suspects vasculitis, because dermatologists are very good in recognizing vasculitis and other skin diseases. So if the dermatologist tells you this is vasculitis and you don't see it in microscope, you should always look twice. Or painful skin lesions. Skin lesions that are not itchy, but they are painful. You should always consider vasculitis. In GI tract, ischemic-like ulcers. If the defects in endoscopy look ischemic-like, you should consider vasculitis. In kidneys, any glomerulopathy, because the vasculitis, as I mentioned before, it commonly affects kidneys. So any glomerulopathy, you should always consider vasculitis. In lungs, any uncertain diagnosis or uncertain X-ray or CT findings, you should consider vasculitis. And finally, always consider vasculitis in any obscure chronic disease, because the clinical presentation of the vasculitis can be very variable. So if you are not sure what's the problem with the patient, and if the patient has a chronic disease, you should always consider the possibility of vasculitis. Okay guys, that's all. Thank you very much for the presence, and see you later.